Hello, I'm Dr. Anurag Bajpai, Pediatric Endocrinologist at Regency CDER for Diabetes, Endocrinology and Research, and I'll be talking about precocious puberty or early development of physical characteristics in boys. Precocious puberty is a rare phenomena in boys as compared to girls, but when it happens, it may be a significant cause of concern because a larger proportion of boys with early puberty tend to have an abnormality or a disorder as a cause of precocious puberty as compared to girls. So if any boy has any sign of pubertal development in the form of hair growth, in the form of acne, in the form of penile or testicular enlargement before the age of 9 years, there is a significant cause of concern. The pubertal development in boys is typically a bit later as compared to girls. Usually the testicular enlargement starts to happen from around 10 and a half to 11 years of age, and this is followed by the development of the pubic hair, resulting then into growth acceleration, changes in facial hair, voice change, as well as the development of acne. Voice change is a very late sign of pubertal development in boys. The pubertal regulation in boys involves the three major organs: the hypothalamus, which is the central gland located in the brain, the pituitary, and the testes. The hypothalamus produces gonadotropin releasing hormone, which acts on the pituitary to release LH, the luteinizing hormone, and FSH, the follicular stimulating hormone, which then acts on the testes to produce testosterone. Testosterone, or quote unquote the male hormone, is responsible for pubertal development in the form of hair growth, in the form of penile enlargement, in the form of development of acne, in the form of change of voice and facial hair growth, muscularity, aggressiveness, and all the features which we really associate in terms of puberty in boys. Precocious puberty in boys is much more likely to be associated with a pathological cause as compared to girls. The problems in precocious puberty in boys can be either at the level of the hypothalamus or pituitary, where we call it as a central precocious puberty, and a significant proportion of them may have an underlying brain disorder like a brain tumor, like an infection, or increased pressure in the brain. So if we have a child with precocious puberty which turns to be central in boys, we have to always do a MRI of the brain to look at any underlying disorder. Adrenal glands located just above the kidneys are also a very important source of androgens, and conditions associated with increased production of androgens from adrenal can also cause precocious puberty. The adrenal disorders associated with precocious puberty include a congenital disorder which is known as congenital adrenal hyperplasia, which basically is a defect in which the enzyme synthesis is defective, so all the adrenal hormones are not being produced and they are all being shunted towards production of androgens. Rarely, adrenal and testicular tumors can also cause the development of precocious puberties in boys. Precocious puberty has significant impact in terms of short-term and long-term consequences with regards to the physical, psychological, and psychosocial implications. The most important implications of precocious puberty, of course, is in terms of compromised height, because these boys, when they come to us, look tall, but then when we really evaluate them, we found that the bones are really enlarged and there is limited time to grow from that perspective. So a timely assessment becomes essential to avoid these complications. The key aspects of evaluation of a boy with precocious puberty include the confirmation of the diagnosis, to classify between central or peripheral cause, and the decision regarding the need for treatment. We have to be carefully examine the child in terms of the physical examination, in terms of the height, to decide about whether the child truly has a precocious puberty. Then we would need to run a number of hormonal investigations, also look at the bone age to look at how far the bones are progressing, and in scenarios where we confirm this to be a central precocious puberty, a MRI of the hypothalamus and the pituitary is absolutely essential. In boys, where we think of adrenal cause, there are adrenal imaging and certain other investigations towards congenital adrenal hyperplasia become absolutely important. GnRH analogs are the mainstay of treatment of central precocious puberty, or where the hypothalamus or pituitary is hyperactive. These are analogs which are structurally similar to the gonadotropin releasing. The GnRH analogs, when they are given in long-acting form, they will desensitize the pituitary, reducing the level of luteinizing and follicle stimulating hormone, the LH and FSH, and reducing testosterone. The start of GnRH analogs is expected to result in decrease in testosterone production, decrease in bone age maturation, improvement in terms of growth outcome, as well as reduction of growth velocity to a normal prepubertal growth of around 5 to 6 centimeters every year. We need to carefully follow these children on GnRH analogs in terms of their growth, in terms of their pubertal status, in terms of their bone age, to make logical decisions about the need for treatment, the increase in terms of frequency, or when to stop the treatment. Other causes of precocious puberty in boys may require certain treatment in terms of the congenital adrenal hyperplasia, where we do treat them using steroids.